everyone. Welcome to our webinar. It's Supporting Child Mental Health Through a Whole of Practice Approach. My name is Meghna and I'm the Program Officer with Children and Families here at the Northwestern Melbourne Primary Health Network. Just before I start, I'd just like to do a quick acknowledgement of country. So here at the Northwestern Melbourne Primary Health Network, we just like to acknowledge the traditional custodians of the land on which our work takes place, and that is the Wurundjeri Woi-wurrung people, the Wathaurong people, and the Boon Wurrung people. We pay respects to elders, past, present, and emerging, as well as pay respects to any Aboriginal and Torres Strait Islander people in the meeting with us today. This webinar is hosted by us and with Emerging Minds as well. So basically, this is the overview of the session. So I'm actually going to hand it over to Matt, and he will go through the panel members and just provide a brief introduction about the content of this webinar today.
Good evening, everybody. Yeah, it's going to be a packed session today. We're going to start off with just a little brief overview of child mental health for about 5 minutes. Then I'll be introducing Mel, our lived experience partner. Then we get a chance to talk to Aaron and Alison from Grow Life, a general practice in Queensland, who are doing all things child mental health related. So, and then we'll get a chance to ask some questions to all three participants. And then we'll hand it over to Meghna to talk through what's happening at the PHN level in terms of health pathways, but also the new EOI that's come out in your PHN, followed by some questions if we have time on that.
Have Matthew, the Child Mental Health Advisor from Emerging Minds. He will also be speaking about child mental health today. And we're also joined by Melissa as well, who is our child and family lived experience partner. And we also have Alison and Aaron as well from Grow Life. I'm going to hand it over to Matt now.
Great, I'm just going to take control. Yeah, so this is a webinar focused on whole of practice for child mental health. Yeah, the first couple of slides are just to introduce us, for those who aren't aware, around what is child mental health. It's a complex subject, yeah, we'll be going through a few slides before we get a chance to talk to Mel, our lived experience partner. Before I get started, I just wanted to make an acknowledgement of obviously the practitioners and the researchers that we work with here at Emerging Minds. But more importantly, the work that our child and family partners do. They participate in all sorts of different projects at Emerging Minds, including participating in the Family Forum. But they do all sorts of interesting stuff like help us come up with content, practitioner content, and I just wanted to acknowledge their input tonight. Okay, so a few statistics. We know that mental, emotional and behavioural health issues are prevalent in Australian children. We know those who experience a mental health disorder, often children who meet the criteria for specialist support. We know that only a handful of these children access services. We know that these children who have mental health challenges often appear in primary healthcare settings with early or mild symptoms that are often missed or misinterpreted. But probably closer to home in terms of primary health care, we know that 35% of children with a mental health disorder in Australia have seen a GP in the last 12 months for some sort of emotional behavioural health problems. So we know that they're in primary healthcare settings before they're diagnosed with mental health challenges and conditions. So at Emerging Minds, we like to talk about seeing the whole child. And I think as a society, we are getting better about talking about mental health and child mental health. But I think when we say the words mental health, there's still that idea that what we mean by mental health is that it's about somebody with a diagnosed mental health condition. So at Emerging Minds, we like to talk about the child mental health continuum. So not only should we be thinking about diagnosed mental health conditions, but we should be thinking about those children who are maybe exposed to risk factors or have certain vulnerabilities in their lives or in their family settings that might put them at risk of a mental health condition. But we should also be thinking about those contexts where children experience positive mental health as well. And obviously children are a mix of all three, could be a mix of all three. So we know that even children with diagnosed mental health conditions sometimes experience positive mental health as well. So it's really important to kind of take all that in when we're thinking about child mental health. Probably the most important thing to think about in terms of the impacts of child mental health is to have a focus on parental adversity. We know that if there's adversity in a parent's life, that can obviously make impacts on their parenting. And we think that there's this cyclical effect where parental adversity impacts on parenting, then it impacts on the child, which impacts on their emotions and behaviours, which then impacts on the parenting. And this can often be a vicious cycle if it's a negative feedback loop. So it's really important to think about child mental health in the context of what's happening at home and what's happening in those parents and carers' lives as well. This table might look complicated, but it's adapted from some really good work from Aracy, just looking at a review of child mental health and what are those protective and risk factors. And so they put them in these really nice domains. So, you know, looking at the child domains, whether they have any abilities or needs that need to be taken into consideration, whether there's any family circumstances or relationships that are protective or risk factors, whether what's happening at school. So one of the big pieces we've done in the past 6 months is looking at a review into bullying. And we know that bullying is one of the biggest risk factors to child mental health. So knowing what's happening at school and who's got their back at school is really important. Life events, these are really big impacts on children, both protective and risk factors as well. So we know if they have access to opportunities or they're exposed to stresses, that this can have an impact on their mental health. And then we've got those wider things. So what's happening at a society level? So, you know, within your own clinic, looking at the at your families who are coming in, what's going on in terms of you know, whether they have access to services and all those sorts of things. And for some of you tonight who might not be in those clinical settings, you might be thinking, what can I do? You know, you're talking about all these domains around child mental health. But if you think about things like life events, And up there, you know, I've put difficult transitions. So, you know, maybe a child's transitioning from childcare over to school, and they're having some challenges. If you have a good relationship with families, you might hear some of these stories, some of these challenges, and that just acknowledging that there's challenges in these families' lives. We know that families who are practitioners who acknowledge those challenges are ones that are really appreciated by parents. So just acknowledging the stresses that are going on in that child and that family's life is it can be really important. And at the other level, if you're feeling confident, you can suggest, you know, maybe this is something that you can speak to some of our staff, one of the nurses or a GP, if it does sound like it's challenging. So yeah, so that's what we really mean by whole of practice. We mean that everybody plays a role, has a role to play in terms of thinking about families and their well-being. So and just to reiterate that message, you all have, whether you're clinical or non-clinical, you all have some sort of transferable skills that are really important to child mental health. Encouraging ongoing care, like I talked about in terms of validating difficult experiences, all those active listening skills that you use, relationship building, and then some more clinical skills in those clinical roles like history taking, formulation, screening, and chronic condition management as well can be really important to managing child mental health challenges. Okay, so I just wanted to introduce Mel McCosker. Just bear with me, my notes are gone. Where are my notes? Sorry. I did have them up. Okay, so Mel is a busy lawyer who is also a mother of two, and her children are aged 5 and 2. She lives in New South Wales and she has lived experience with a variety of services, including Tresillian, Gidget House, NDIS, and a variety of medical professionals and GPs, as both children have chronic conditions, and her second was also premature. She's actively involved in sharing her expertise to help inform practitioners and services to improve patient experience. And Melissa was selected as a member of our family forum and is enjoying contributing. So welcome, Mel. Take it away.
I'll just unmute myself. Hi, everyone. I'm currently off camera because I'm having a bit of a glitchy internet day, but I'm definitely here and hopefully we'll be able to run through this without too much issue. Can I have the next slide, please? So one, I think, important thing to think about when you're thinking about a child in this family and sort of in a general practice setting is looking at the whole family unit, because I think odds are if you've got a child that's having some difficulties, there's probably something else going on at home, and that child's difficulties are probably impacting the other people in the home as well. So I think really important, while it's great to be focusing on that child and getting that child the help that they need, it's probably important to take a really good look around and see what's impacting who and how it's all going on. So obviously you're going to have aspects of the family unit, the family dynamics that might be contributing to those child difficulties, but equally you might find that, you know, these relationships are suffering. So parent and child and sibling, particularly if there's a whole focus on the child's issues and what's not, and and not enough focus on what's going on around it. You know, children are really good at picking up on, well, such and such sibling is getting all this attention because they're going through something. And so they might be acting out. Equally, you know, parents might be feeling that their relationship with the child is strained because of the difficulty they're facing. So I just think there's a whole lot going on when you've got a family dynamic. So it's probably important to look at the child, obviously, and then beyond that as well. Next slide, please. So probably something that you would see a lot of, it causes a lot of stress, is infant sleep. We all know how important sleep is for us, for our children, for our ability to function. And so it's probably one of those things that you're going to be seeing families come in about and ask questions about. And one of my key things, because I had a lot of trouble with my kids' sleep, is that lots of people were really, really excited to normalize the difficulties I was having and saying, yeah, that's totally normal. It's developmental. But when you're in the thick of it and when you're finding it hard, I think it's really important to try and acknowledge that it's definitely normal, but it's also hard. And not coping with it is common and human. I think one of the biggest stresses that parents face is about sleep, partly because they really need their sleep, partly because they're worried about how that is going to impact their child's development if they're not getting enough sleep, or, you know, if their child is just cranky like mine were because they weren't getting enough sleep. So just, you know, keeping that in mind when you're reassuring someone that what they're going through with the sleep is normal, but that, you know, that is hard, and, you know, recognizing the impacts on mental health of the parents and the child if the sleep is not quite right. And this flows into my next point. We all know that social media, TV and internet have kind of created this myth of, you know, parenting being, you know, some people being born parents and it being really easy, and, you know, that other people are coping better. And I have this vivid memory of dealing with my first child's sleep and going to Tresillian, which some people would call sleep school, you know, family centre, where you do a stay and you get some help with sleep and other issues. And I was sitting there, you know, saying to the nurse, oh, I don't know why I can't cope. Everyone else is coping. Why is this hard for me? And she just turned to me and said, well, we wouldn't be here if everybody was coping as well as you say they are. We wouldn't have a job. We wouldn't have a waiting list. That's just not the case. That's the perception. So I think it's really easy to put a little bit of context into these sort of consultations. You'd have to be having people come through the door all the time talking about their child's behavior or their child's sleep or something that is relatively common, and they may not realize that. And it might be as simple as just saying, you know what, I've had 3 of these consultations today. You're not the only one going through this. It's literally been the same sort of conversation I've had with my doctors about how often my kids are sick at the moment. And just, you know, sometimes hearing that you're not alone in this, other people are going through it. And, you know, people who have it together may not, you know, is really, really important, I think, for everybody's mental health. Checking in, obviously, with the family that you're dealing with, because I think sleep really impacts everyone. If someone in the house is not sleeping, whether it's a child, whether it's a toddler, whether it's the parent, everyone is impacted, and we know how much of an impact a lack of sleep can have on your mental health. So I just think it's, you know, if a family that's coming in about a child's sleep, it's probably good to check how everyone's sleeping as well. Obviously offering a variety of support and options when someone comes in. I mean, infant sleep is controversial. There will be people who are, you know, adverse to seeking help for that reason. So, you know, providing resources, providing support to look into what the right approach is for the family. And another important thing, obviously, you know, if someone's coming to you for a sleep issue with their child, it's good to do a good thorough check and rule out medical causes, because sometimes it's a simple fix as many of you probably already know. Next slide, please. So one of the things I think is really important is thinking about how to make general practice and your practice as family friendly as possible. And I tried to think of some of the things that really, really helped me in terms of, you know, seeking medical attention for my children. I recognize at the moment it's been really hard with what's happened with COVID. So these are just some things that came to mind. I think online booking can be really, really handy for parents. I know a number of times I've had a kid sick in the middle of the night, and the fact that I can literally get out my phone while I'm trying to pat a child to sleep or feed a child or whatever it is, and make an appointment in the middle of the night for the next day, or see that there's an appointment available, has been really, really reassuring. Because there's nothing worse than trying to get on the phone with screaming children in the background, try and get an appointment the next day. You know, if you're a bit worried about your child and you want to have an appointment booked for the next day, just knowing you can do it, and just the ease of how quickly you can do it on your phone with one hand, I think is really, really helpful. Obviously, having the option to speak to someone is also really, really good, but I think having both options is helpful. If you've got a really long wait at the doctor, sometimes it's really helpful if you've got young kids with you, if front of practice staff to say, look, you know, we've got like a 30-minute wait. Do you want me to just give you a call when we're getting closer? Or we're really behind today. I'll call you when we get close and make your way in. Sometimes that can just take out the stress for everyone. The people in the waiting room included, if there's kids, because kids hate sitting, as many people would know. And my kids in particular got very anxious in clinical settings. So it was much easier if sometimes it was just able to take them outside. If you've got a space for, you know, almost like a crying room or a place to feed the child, make that known, let the parents know. It's always good to know you have the option if your child just starts losing it or all of a sudden wants a feed that you weren't expecting. Simple things like changing facilities, most places would have that. Toys have been a bit difficult due to COVID. I know I always have a love-hate relationship with toys at the doctor, because I'm not sure if, you know, they're going to be clean and, you know, who's touched them, and, you know, is this child going to break them? But I think there's room where possible to have some easy to clean toys, or just some paper and pencils. I mean, most parents try to be organized when they leave the house, but you never know. Sometimes it's at the last minute. So it's really helpful. Otherwise, I have, like, you know, my 5-year-old saying, I'm bored, I want to go home, while I'm trying to have a serious conversation with the doctor about that child. So that can be handy. But sometimes I guess you got to think outside the box as to what's COVID safe and just generally easy in your practice. I think sometimes when your child is just being a kid, it's just handy if, you know, you get that look, or you get that sort of acknowledgement of, hey, look, you're doing what you can, and kids are going to be kids, or, you know, it's all right, you know, dear, I know it's hard waiting for the doctor. So sometimes those little acknowledgements, because I think often the parents feeling super self-conscious about what the kids are doing, that can be really helpful. I think my kids were really triggered by anything clinical. So where possible, if the waiting reception area is a bit less clinical, I think that can help kids sometimes, because I think some kids, literally just that walking into a clinical environment can be quite stressful. I know some work was done, and I really found it quite useful when we had COVID vaccinations for the 5 to 11-year-olds in New South Wales. The main hub, they had a bit of consultation about trying to make it as kid-friendly as possible, and there were nice bright coloured pictures and certificates and things. And I think that just eased some of the anxiety that many of those kids had about having a vaccination. And bright and welcoming interactions with kids are always welcome. I think clinical, non-clinical staff can really pick up on how they're interacted with, and they love being involved. So bright, friendly face is always useful. Next slide. I think another thing that's always really challenging to think about is how we can make practices more accommodating for vulnerable families. I think one of the hardest things for everyone is trying to fit things around work, and that goes for pretty much every profession, I think, out there. So where you can have some flexible times for early morning, after 5 weekends. Obviously, that's always a challenge, but having some options available, because obviously people's work dictates, when they can get out, and not all workplaces are flexible. Obviously, flexible billing practices where needed, having that option sometimes, and that discretion if you need to for a family. As I said previously, online and phone bookings, probably particularly useful for some of the vulnerable families, having access to an online booking, so you can make a booking when you've got someone who has a better command of English, or when you can only do it outside hours, so online booking is good, but equally phone bookings if you need to sort of chat to someone, and options to support languages other than English. I think it's great when practices indicate languages that are spoken by their staff, and it doesn't necessarily need to be language spoken by the doctor, but if you've got a receptionist who speaks a language, especially if that's a community language in the area, that's really, really helpful for people as well. Last sort of point is difficult conversations. I know you probably have to have lots of them all the time, and I've been on both sides of this. It's really hard, and I think we have this tendency to not want to have them, or to try and delay it. But you know what, difficult conversations are hard, but the longer we wait, the harder they get. I think they're necessary, and I think that's something to remind ourselves of, particularly because I know in my experience, most people say, I wish I got help earlier. So sometimes having that conversation gets that person the help earlier, especially when, the conversation is hard, but the after part may not be. So it's just, helping people through that. I think too, these things can be uncomfortable, but we know with children, early intervention is key. And so the longer we wait, it can impact the child. And it's that, I always come back to, I think circle of security taught me a lot. And it's that being stronger and wiser, that, oh, this is an awful conversation. This parent may not like it, or this child may not like what I have to do, but I've got to do it. I've got to do it for them. It's the right thing. And sometimes it's just about framing it. I think sometimes it puts people at ease to say, look, we're going to investigate this. Worst case scenario, we've found that there's something, we can deal with. And you know what, if we find there's nothing, that's okay as well, because sometimes you will find nothing. Sometimes you will go down a path and there will be no diagnosis, or it was a short-term behavioral thing. So I just think just remember, look, it's hard, but let's get through it. Let's get the person help, and just be mindful of how the conversation goes. And I think that's it for me.
Wow, thanks, Mel. That was fantastic. Such practical, articulate advice. I wrote down, not coping is common and human. And for somebody who is halfway to being a dad, I think I'm going to just grab that advice and use it when I need it. So thank you. Yeah, really practical advice. Thank you. Yeah, so I just wanted to introduce Alison and Aaron Chambers. I'll get there. So Alison is an endorsed midwife, an RN. She provides antenatal and postnatal care embedded in general practice, along with child health services. After many years' experience as a paediatric nurse in Australia and overseas, Alison obtained further qualifications as a midwife, and as well as having 3 children of her own. Alison set up Grow Life Medical with her husband, Aaron, in 2017 with the goal of improving health through connection. Alison established the Grow Life Medical Parents Group and child health drop-in services, and now offers pregnancy and postnatal care for families. Aaron is worked in general practice since 2006. He's passionate about family practice, including pediatrics and obstetrics. After completing his medical degree with honours at University of Queensland. Dr. Chambers served as a RAF doctor, conducting humanitarian missions and evacuating wounded servicemen from the Middle East. Dr. Chambers co-founded Grow Life Medical with Alison, based on a shared belief that growing a healthy community is based on building the strength of individuals and families through genuine connection. He is also a co-founder of Allergy First, GP Consults and Cub Care, and is the GP Liaison Officer for Queensland Children's Hospital. Take it away, Arison. I'm mixing the names together.
No, that's what, you know, my parents actually go Arison, you know, and so that's funny that you said that. First of all, I just want to say thanks so much, Mel, because it was actually quite heartening to hear everything you had to say, because it pretty much embodied, I suppose, what we've tried to
what we believe in. Yeah, it was like, oh my gosh.
That was quite nice.
Grab the next slide, please. I think we might just take over control, if that's all right. So yeah, we've been asked to have a chat about a whole practice approach to infant mental health or child mental health. And the idea is to kind of really just think about how you and your practice can support the mental well-being of children by just making it fun, really. I guess that's what we've mainly tried to do, is just kind of put the fun back in general practice and be genuinely involved in our community. I really love it. And there was a great GP educator mentor, John Buckley, he's in Queensland, who always at the end of every single teaching session, he would say, identify one thing you'll change about your practice. And I've taken that on as like a little mantra, that any time I attend one of these, I think, what's one little thing that I can change? And I'd encourage you to do so in your own practice. Let's see if we can get the next slide. There we go. So why is this important? Well, we're turning tiny human beings into fully grown adults, and we all want a responsible, cohesive, great society around us as we get older, so that we've got people who support us in the future. And I think, you know, children really are our future. So, so often though, this is kind of the Instagram type image of what it looks like to be a happy family, and you've got smiling, laughing kids, and, you know, mum and dad are super happy. But I don't know about your family, for those of you who have kids, but it's so often not like that. And really, I think we're all normal human beings. But I wanted to touch on initially, to play this video that really, so this is a documentary that you can actually go and hire or watch yourself. It takes an hour, hour and a half, I think. But some years ago, it was early in the time where I started at the Queensland Children's Hospital, this was played for some of the senior leadership team to just think about how communities change the health of the participants in those communities, and how family environments change the outcome for children. So I'll just get you to watch it, and we'll go on after that. Are we getting the audio there? Actually, might need to unmute Magna.
Magna.
Magna, if you can take control back.
Does it work now? I've unmuted.
Okay, can you take control back?
If you can take control back and just go back to that slide and play the video, that'd be great.
Yeah. Oh my gosh, what has happened? This is not.
If you press escape, I think it usually
Oh, is it working now?
No sound.
no sound. That's no. Maybe can we share? Can we share that with the audience afterwards?
We can share that. Not a problem.
That's a real shame. So unfortunately, this really sets the scene in this video. But if you can move on to the next slide, Magna, that'd be great. I'll let you. All right. So the idea behind that video talks all about adverse childhood experiences and how that things that happen in our childhood are imprinted on us really forever, and encourages you to think about not just the individual in front of you, but just like both Matt and Mel have said, thinking about the family context and what's happening around that individual who comes in front of you, because they're not isolated, especially as a newborn. They're a parent-baby dyad, and then right through their life until they're an independent human being, they're entirely dependent on their family, and they're growing up in a community that has heavy determinants on what's going on for that individual. So this is what Alison and I came up with before we'd even opened the practice. So maybe Alison, you want to talk through about where this came from?
I guess it was really, I mean, it really talks to everything that Mel was really chatting about earlier with any patient interaction. I mean, really with children in particular, we are focusing on that child in front of us and those immediate concerns that are raised and all the different aspects of that child. But immediately we're thinking, what's happening if the family around them, with the siblings, with their other supports, any any other factors, and with that looking at adverse childhood experiences, parental adverse experiences, and then obviously extending that outwards further again to try and look at what are their outer supports like that may well be contributing to what they're actually presenting with on that day. I mean, this could be, I guess, reflected back into, say, what Mel was talking about with the family that comes in concerned with a baby that doesn't sleep. What are they actually telling us? Is it the baby that's not sleeping, or is it the parent that's not sleeping? And where is their actual issue, and looking beyond that immediate factor. And this is really for all families or any patient really that we have engagement with, and this is shared across all members of the team, right from reception. When they walk in the door, it was really lovely to hear Mel mention, if you can have that warm welcome when they walk in, straight away, that family is feeling a little bit better about being there. They don't want to be there. But if you can do something that makes them happier to tell their story, to make their child a little bit less worried if they're, a toddler about being there, or even a mum with a newborn who's got a screaming baby, that you can help them with somewhere safe to go and feed their baby, they're going to feel a little bit more happy to tell you their story.
I guess with this model, you'll see on our logo down the bottom left there that actually the byline is patient, family, community, and I guess that's where there's a little bit of belief that comes into this. Like I've always felt that general practice has gone a little bit missing in thinking outside the clinic walls in a lot of circumstances, just because of the day-to-day demands and the requirement for, really, some financial pressures. But I think sometimes that's where the magic comes, and it doesn't have to be much, but we've really consciously thought about how we can get actively involved in the local community, and small blocks of time do genuinely suddenly make it quite fun. Like we've done things like do kindy outreach programs, we go and do a little hand washing clinic, school fates where you go out, and that presence in the community, it's a unique part of general practice. We are actually members of our local community, rather than being kind of someone you see like once a year and it's an isolated thing. So going out and getting involved in those is one of the things you could consider doing. I think it makes a massive difference to the way you're perceived and the interaction you have then with your patients when they do come through the clinic door. Because walking down the street and being recognised by a young kid, instantly the next time they come in, they'll be really excited and know who you are as a human being.
Can we do next? Yeah.
Yep.
Thank you. So part of our, I guess, connecting with the community at Grow Life was the establishment of a parents group that was established back in 2017, and it started very, very small with, the few young babies that had come through the doors when we were very, very new. And that was a facilitated parents group. So we'd have set topics, I guess, we'd talk about. There was support there. But the main goal was that connection, social connection, whilst having a touch point really in that early life experience. There wasn't any restrictions on who could and couldn't come. If there were people from outside who wanted to come, friends of the patients who wanted to come, they could all come. And what was quite amazing is where this sort of grew. It became more and more families came to know about us. we had to change locations to a park because there were too many people. And we also became an online forum as well, for women and families and dads actually as well, to connect, ask questions of each other, raise concerns, and find that support in their local community, be it face-to-face or online. Aaron, one of these ones in here, these were just a few comments that came up recently, well, a little while ago now, on our Facebook site.
So maybe this actually, I've got to be careful that I don't actually get some tears that come up around this, because this really means quite a lot to us. So back in, I think it was February this year, there was flooding again in Brisbane. And one of our practices is in a community that is really prone to flooding and was terribly flooded in 2011. And really some of the trauma that came up around that, and I know in Melbourne you're dealing with something sort of similar recently, some of the trauma that came up around that really pushed some buttons for people who've been flooded in 2011 and then again in 2022. And our practice actually came within about 5 centimetres of being flooded itself. But then we saw this pop up on the Facebook group amongst the local community. And this is a post that one of the mums put up where she had been flooded and needed to clean the reusable nappies. And within minutes, her desperate request on that Facebook group resulted in a whole bunch of offers to clean all these reusable nappies. And, you know, this speaks to what we are doing, is that if we genuinely catalyse social connection in our communities, that is what promotes good mental health. It's not about pathologising it and creating a diagnosis and then treating it. We're nipping it in the bud and allowing people that social connection and making sure we actively participate in it before it even becomes a problem. And so I can guarantee you this turned around a situation where you could have had someone in your office really with not really knowing what you can help do about it, because you know you can't solve an issue where someone's been flooded and they no longer have a laundry. But by those small steps that you take at a practice level to help people be in connected with each other, I think it can genuinely make differences like this. What's happening there?
So that was just another comment actually that was made recently when we did a survey for just looking at breastfeeding continuation rates amongst our population, and many of the comments came back with focus on this parents group and the free services that were available to really allow them that connection, and that, you know, need to feel supported really. Yeah, there was many comments though.
Yeah, and the social connection is important, not just from a feel-good point of view. There's a really good sort of systematic review and meta-analysis that demonstrates that measures of social connection are a more powerful measure of mortality, a more powerful predictor of mortality than not smoking, than normal weight, than healthy eating, than pretty much, and the normal blood pressure. They are way more powerful than most of the interventions we actually normally offer in the clinic setting. So this just talks about how what we've done is to make sure you've got a really conscious approach to thinking about that unique part of practice, which is the longitudinal interaction over time. So we won't dwell on this because it's unique to your clinic, but it just, I guess, indicates how it's a good idea to think about it and how to create points in time through the normal patient journey to ensure they feel connected and they've got stuff happening. So.
Yeah, and so really you can see, I mean, this one's just focusing on, I guess, on early life, really starting from pregnancy. And really we just wanted to draw your attention to, I guess, for our situation being set up, we're, you know, privileged. We've got, you know, embedded midwife, we've got embedded lactation consultant. We've set up this child sort of drop-in clinic as well. But those services do exist in your community. So I would probably highly suggest getting in touch with who is around in your local community that can combine with your care to have a touch point of help for families who may need a little bit of extra help. And, you know, literally all families do need that help. You can kind of follow it through as a journey, as you see, you know, from pregnancy. Often I would have some involvement in the pregnancy, then would touch back in post-birth in those early few weeks with asking some of those difficult questions that maybe if there's a short 10-minute, 15-minute, whatever appointment with the GP, it doesn't quite get to that point, but a GP might flag with me, oh, look, she seemed to be really focusing on, oh, we're just not getting any sleep, you know, can you check in with them? So I can then touch in with them, you know, in a couple of days later, see how they're going, offer them to come in again if they wish, or just have that little bit of extra contact. I mean, you can follow it through, obviously, various points along the way, be it with the GP, then also connecting them into those other services that are out there, be it we do some embedded music therapy, it's like family music therapy. It's about connecting with your child through music. Perhaps your practice could offer like a circle of security parenting program, you know, once a month, or you know, tuning into kids is another really good parenting support program. But just really thinking about all those little bits along the way where your families can feel supported.
And I guess encouraging warm handover between the team there. So, you know, even to the extent of reception being aware that if they see some markers for distress in a family, making sure they bring that to the attention of the nurse or the doctor.
And I think as well, yeah, think of that attention of the nurse. So look, often in all your practices, the nurses will have some involvement because there might be childhood vaccinations or ways and measures and things that need doing. That is prime opportunity just to have a really quick chat. Oh, look, how's your 2-year-old going? Has it been really hard for them having this new baby? You know, or are you getting any rest? Have you got a grandparent around or a next door neighbour who'd be able to help? You know, just those little touch points are really important.
I think this was really touched on before in both what Matt and Mel talked about, is the little markers that come up that might make you think about, do we need to proactively start to make some intervention with this family? So just a bunch of questions that where the parent comes in, just have a think about whether you need to delve into that in more detail.
Oh, this slide was really just, I guess, touching in again to what Mel had mentioned around the importance of the different interactions that one family might have, and it was really just, for example, you get a phone call, reception takes that phone call, it's a mum who's sounding pretty tired on the phone. Oh, I've told I need to put my baby in to be seen. Reception ensures that the mum and is well aware of what the process is from them, when they can be fitted in, and obviously try to sense the urgency on the phone. They understand, look, how long the appointment will take, you know, any costs associated, and then go on from there. When they arrive at reception, it's very friendly, warm, open welcome. Let them know where feeding is appropriate, and just really try and welcome them as much as we can. Everyone does try and do this, obviously. We've spoken about the nurse's role a little bit as well. Obviously, make sure that departure process is really smooth as well, because by then, families are getting a bit frazzled, as Mel was saying, because, you know, either there's been delays or whatever. Also, just making sure families are aware of any services that are in existence. So having a quick flyer you can hand out to them just so that they can touch in when they need.
I think I understand it's a little bit different. So in Queensland, we have far fewer child health nurse clinics than you have in Melbourne, and I understand you've got quite a few more. But even if you've got a different community of practice, I think making sure that you've got a really active participation and awareness, and working with your local child health nurse clinic, as opposed to sort of standing in silos. You know, we so often get siloed in medicine, and I think just making sure you've got like an active relationship with them, so that this stuff can be happening there by proxy, if that works for you, or if you can host it in your practice, then fantastic.
Yeah, and that's it. Keeping the communication open, that's what will.
Can we get some comments into the chat? So are there any particular things that your practice struggles with around this sort of stuff, and ideas or questions that you might have relating to that? I might jump on from there and try and move to this poll. So whilst you're thinking about what you're going to write in the questions in chat, we've also got a poll that we'd like to pop up, just to talk about which family or like whole of community interventions do you have currently set up in your practice. And for those who aren't sure, ACEs is the Adverse Childhood Experience Questionnaire. Good. Whilst we're waiting for you to do the poll, there was one question that came through earlier, and that's that are refugee kids at increased risk of mental health problems? The answer is yes, almost certainly, in that effectively by being a refugee, they have at some stage gone through adverse childhood experiences effectively. And I guess there could be a big range of those things, anywhere from having come from a warlike environment and to having lost a parent or had a parent incarcerated or been in incarceration themselves, and potentially witnessed violence or things like that along the way. And so that's the general gist of the Adverse Childhood Experience Questionnaire. It's worthwhile, if you've never done it, to do it yourself. Actually, you can just Google Adverse Childhood Experiences Questionnaire. It's amazing the linear impact that has upon all sorts of measures for risk of depression, of alcohol, of smoking, of obesity,
cardiac health,
disease,
like all sorts of things.
Disease,
and mental health is just the tip of the iceberg, really.
Have we got a result of that poll, Matt?
Yep.
None. So yeah, that's interesting too. No one's using the ACEs questionnaire. Yeah.
That's excellent. Circle of Security or Triple P embedded within the practice. It'd be great if you could put in chat as to which one you're using. They each have their particular role. I think, the way I take it is Circle of Security is excellent where you're trying to promote better attachment between parent and child. And I noticed actually, Mel, you had Stronger and Wiser in what you expect of the clinician. But I really love that model, and I think we talk about it a little bit later on. About where is it? So it's just about the adverse childhood experiences.
It's also coming back. Yeah, this is sort of some points that Mel touched on. That it is okay to have uncertainty, and appreciate that you can touch in again. Like things don't have to be solved on the spot. It's really, you're there to listen, to ask those hard questions, and start to, tread that path really with the family.
And listening and time, I think, that's a powerful tool. And I think, Mel, whatever you said was fantastic, because we're almost reflecting exactly what you said in terms of refer early. If you've got a concern, refer early. That's the worst that can happen, is there's nothing wrong. And I think we've pretty much reiterated most of those messages through the way. These are just some tools that we use in Queensland. You'll use your own local child health. I think Victoria uses the Parents Evaluation Developmental Status.
I think it's the PEDS used, I think, down there. Could be wrong.
But just using that as a kind of a scaffold for discussion, it's really good if you have something to fall back on that front. These are a couple of resources that I highly recommend, if you haven't already got them used routinely in your practice. They are really good guidelines. So, maybe in the nurse's office around where you vaccinate.
Yeah, because often you're asking questions, how's baby go? What milestones are they needing? And these are the ones, obviously, when you really need to go, oh, hang on, we might need to look into this further. But a lot of these may be physical milestones, but they may indicate some other, mental health, underlying issues, emotional problems, attachment problems, all sorts of other elements for the child. So really, really important to try and have a red flags guide up somewhere central. In fact, in every room is not a bad idea, because it does it's really some alert times.
So that one's up to school age. And then this is a relatively newer one, which you may not be familiar with. It was only launched, I think, 2 years ago. And this is the school age red flags guide. So it kind of carries on into a slightly older population, and really encourages you to just have a think about what the parents' concerns are, even have something for them to flag what you're going to ask and discuss. And then things to explore with that family, and then a bit of a framework in order to have a think about, for example, those transitions between different key age points. And then I don't think we need to go on about what to do once you've identified a problem. That's probably a topic for another day.
And this is just looking at some of the potential things you could do in your practice. I mean, obviously, some of you have already got Circle of Security or similar parenting programs. Having things embedded does make it easier for families to connect and to feel that they are welcome. I like that comment at the bottom there. You do certainly learn a lot about yourself once you're a parent. So good luck with that, Matt.
There's just pointing to some resources you may find useful, including Emerging Minds. Obviously, they've got a heap of resources that are really useful for parents. This is a little flag, we won't talk to this in detail, but just remember, if you've got kids in your community who are in out-of-home care or foster care, pretty much by definition, they've been exposed to adverse childhood experiences and probably need a much more in-depth assessment and a lot more support. So just remember that they're at much higher risk of all sorts of, more on the disorder end rather than on the health end, I suppose, is much more likely. So that's what we've tried to have a chat about, really just thinking about not so much the nitty-gritty of the individual clinician assessing. It's probably a lot more about how you approach this as a whole of practice. Think about your community, how you are part of it, and how all of your team really important in doing that.
Important. So hopefully you've all found maybe, I've got one little idea that you could instill perhaps in your practice after this session, be it from things Mel has said or from us. But there are simple things you can instill that will really make a difference.